All right, good morning, everyone. Welcome. I just wanted to start out by letting you all know who I am. My name is Shanae Ollison. I am new to the YSC family. I just want to tell you a little bit about myself. I was diagnosed with stage 4 metastatic breast cancer in August of 2022. I have just completed my active treatment as of June of this year. So I've had a vigorous chemo regimen, mastectomy, and also radiation. And now I am on maintenance medication to prevent the recurrence. I'm so excited to be a part of YSC. I reached out to YSC because I really was looking for a sense of community, and it has very well been all of that. So I'm really excited to connect with everyone here and have a support system and be a sense of support for someone if I can. I really appreciate you all joining us this morning and giving us your time. But we also have a very special guest here. Her name is Jamie Notman. Jamie is a board certified reproductive endocrinologist with years of experience treating couples and individuals with infertility. She serves as the Director of Fertility Preservation for CCRM New York and the Chief Medical Officer of the Chick Mission. She also brings with her personal brand of intelligence, no nonsense, and honesty to pushing fertility preservation options for cancer patients forward in our board business. When not inspiring her patients and all of us, or her 2 grade school age daughters, she's running marathons faster than should be legal. Everybody, let's please clap our hands, give a warm welcome to Jamie Notman. Now, before Jamie does get started, there are a few things we just want to go over. I do want to encourage everyone, if you have any questions, please put them in the chat. We will try our best to go through the questions as you are asking them to get you the answers. But if we do miss any questions, we'll try and circle back at the end to get your questions answered. And also, if you do feel like we missed a question, please feel free to put it back in the chat again. I apologize. I will try my best to get all the questions answered. Please limit your question to 1 question until everyone has a chance to have had a question answered. Again, at the end, we will try and go back and answer any additional questions if you had any follow-up. Another ask we have is please keep the questions general. Specific medical advice or personal consultation is not necessarily something that we can give in this forum. So general questions are very much welcome, but if you have something specific to your condition, we want to refrain from asking those questions. I think that is about it. Again, any questions you guys may have, you can also send me a chat separately if there's something that you'd like to ask on the side. But other than that, we'll go ahead and get started. Jamie, I will give you the floor.
Thank you, Shanae. Thank you for kicking it off, and thank you to everyone for being here on this now beautiful Saturday afternoon, although we were told it was going to rain, which shows me that the weather people have no idea what they're talking about. But be that as it may, I'm really honored to be here and represent Chick Mission as the Chief Medical Officer and talk to you a little bit about the fertility options for patients who are diagnosed with breast cancer. So a big part of what I do is what we call fertility preservation, or freezing something of your fertility. Now, that can actually be freezing eggs, it can be freezing sperm, it can be freezing embryos. But what we do frequently for young patients who are diagnosed with breast cancer is freeze eggs. And the reason that we freeze eggs is because, unfortunately, a lot of the medications that are administered for women who have breast cancer can reduce their egg quantity and quality fairly significantly. So by freezing eggs, we give women the opportunity, or couples the opportunity, to have children when the treatment has concluded. In general, the world has changed a lot since I started doing fertility treatment or became a fertility doctor, because now it's pretty standard of care for young women who are diagnosed with breast cancer to be referred to a fertility doctor to discuss their fertility options right before treatment has started. Many years ago, this was not the case. And oftentimes, unfortunately, young women underwent treatment and they were not provided with opportunity to freeze something ahead of treatment, and then they were rendered infertile. But that's really, luckily, in most major cities, not the case anymore. So what happens is the oncologist will generally see a patient. She will be diagnosed, and then the patient will be sent over to me pretty quickly, right? I'll see that patient within 48 hours. And in general, we can start the fertility treatment within 48 hours so that we lose no time. So we minimize the delay from diagnosis to treatment, so that once the fertility treatment, which generally takes about 10 days, is over, you can sort of flow right into the treatment that you were prescribed for the cancer. I would say for many patients, I've worked with a lot of patients over the years, the fertility portion is actually, it's sort of uplifting, right? Because a lot of times, like, you're in this state of like, everything is just grim and morose because you're talking about major surgery, toxic medications, the whole works. But fertility treatment is sort of thinking about the future and a time when this may be in your past. And so I think for a lot of patients, they find the fertility treatment as like hope, right? And possibility of what could be. I also think that knowing you have something there, right, whether it be eggs or embryos to use when the treatment is concluded, is also very powerful because it allows you to have hope for the future. So that's generally how people will talk about the fertility treatment. In terms of the process, probably most of us have known somebody who's gone through IVF or somebody who's gone through egg freezing. So it does take, those are my dogs in the background. It does take about 10 days of fertility injections. Give me 1 second. Sorry, give me 1 second. Sorry, while animals are great, they're very loud. So you probably have met someone who's gone through a fertility course of fertility treatment, and it does take about 10 days of hormonal injections. Over the 10 days of the hormonal injections, you're coming into the office every 2 to 3 days for blood work and ultrasound, and we're evaluating your response to the medications. And once the follicles, those are the shells that hold the eggs, get to be a certain size and the estrogen reaches a certain peak, that's when we extract the eggs. The extraction takes place in our off most of the time in the office. We have anesthesia that will come in and we'll administer anesthesia and we'll extract the eggs vaginally. If you're freezing your eggs, at that point, the eggs are frozen immediately, right? They are not evaluated for any genetic mutations or any sort of chromosomal problem, because you can't check eggs for any chromosomal condition. All you can check an egg for is its ability to be fertilized down the road. But what I tell patients is it has a ton of eggs have potential, right? They have options, they have choice. And so then those eggs can sit there. And once you are ready to have a child, we can take those eggs, thaw them, and fertilize them. A lot of times young women with breast cancer are diagnosed with a genetic mutation like BRCA1, BRCA2, CHEK. And these mutations can be screened out in the embryos when we create the embryos. So this is another advantage. I would say, a common concern that we get, or a common question we get, is will the fertility medications worsen or upstage my cancer? And what we always tell women is no, it will not. There's no data that by taking any sort of fertility medication you're going to upstage your cancer. So that's a really reassuring piece of information. We also give oral medication to decrease the estrogen level so that when you're going through the treatment, you don't have as high estrogen levels as somebody else might have. So that's another good sort of thing to know if you're considering going through the treatment. In terms of number of eggs, we get asked this a lot, like what's a good number? It varies based on your age, right? So I think that sometimes we get like very hung up on what the number is and how many we need, when the reality is, I think it's more important to go through the process and give yourself the choice and the options. The one thing that we often forget to talk about or is ignored is the cost. And the cost of egg freezing can be pretty high, right? And so there are a lot of organizations out there, Chick Mission being one of them, that will support individuals as they're going through the process and can often provide them with financial assistance. And most fertility clinics will also modify the overall cost so that patients are able to undergo the treatment. I think the hardest thing for somebody, somebody who is diagnosed with breast cancer and is going through fertility treatment is that there's so much unknown, right? You're sort of like, I don't know where my cancer diagnosis is going to go. I don't know if I'm going to have these eggs or use these eggs or what their future is. But I think that the important part of the egg freezing is the fact that it gives you options and potential. So I always say, whether or not you come through and you get 2 eggs or 22 eggs, I think it's helpful because it then allows you to know that on the other side, there's something waiting for you. I think in terms of the procedure, I think it's pretty doable for most people, especially compared to what you go through when you have a mastectomy or an ovary removed or a part of your colon removed, right? These are all much more arduous procedures that women go through as opposed to the egg retrieval. I'm very technologically terrible. I don't know if that's even a way to describe it. I'm going to try and see if I can get the questions, although I don't even know where one finds questions. So Q&A. Oh, there you go. Oh, no.
I think
Questions?
we're good right now. I don't think we
Okay.
have any questions just yet.
Okay.
But while you're there, does anyone want to jump in and ask a question while Jamie's opening up the floor? Andrea has a question. Go ahead and unmute yourself, Andrea.
Thank you. Jamie, I'm curious what your thoughts are on how long after treatment a frozen frozen ovary can be put back in, and what are the concerns, I guess, some in particular if you have like hormone negative cancer, what are the concerns as far as like putting the ovary back in any fertility meds that you need to take in order to get things going, or to do an egg retrieval at that point in order to get an embryo and that sort of thing?
So that's a great question. I would say that ovarian tissue cryopreservation, so taking pieces of the ovary out and freezing them, are definitely in their infancy. I, have done this for a long time and I've never seen a patient do it, nor have I ever done it. So I probably couldn't give you the most up-to-date information on that. But I would say that once your treatment is concluded, if you did not have an estrogen sensitive cancer, I don't see why you couldn't put that ovary or ovarian tissue back in pretty quickly. There are very few centers in my experience around this country that do ovarian tissue cryopreservation and do it well. So I would say if you are opting for that, which most of the time we only do for women who have never gone through menses, right? So they're pre-pubertal, so we can't stimulate their ovaries. You should go to a center that is really like one of the foremost centers that does this.
Thank you. Yeah, I was lucky enough that I actually had mine removed last year when I was diagnosed, and so, but now it's like the issue of like you said, not many people have put them back, especially in the States. So I'm trying to figure out like
I'm like,
who can do it well.
because I do not know what the answer is.
Okay, but I appreciate your answer. Thank you.
You're welcome.
It looks like we have a few questions in the chat. Catherine, I do see your hand. I will ask her the question in the chat first, and then next I'll let you go ahead and ask your question. The question in the chat is there any known difference in a risk of recurrence after pregnancy, after a breast cancer diagnosis? Does the risk potentially vary based on whether it is traditional pregnancy or IVF?
Gotcha. So that's a great question. And no, there does not appear to be an increased risk of recurrence after pregnancy. The time delta from diagnosis and treatment to when you should conceive varies for patients, but usually most of the oncologists will say about 2 years. It becomes a bit trickier when a patient is on tamoxifen, because ideally the patient should be on tamoxifen for 5 years post their diagnosis to really reap the benefits. But there are definitely physicians that will allow patients to break in the middle of the tamoxifen such that they can get they can conceive. In terms of IVF pregnancy post cancer, I try to always use a woman's natural cycle to limit any exogenous hormones. So rather than doing a medicated estrogen patch, intramuscular progesterone, I tell the patients, let's just use your normal cycle. A week after you ovulate, we'll put the embryo back in. And maybe it's just me feeling better about that, but I do think it reduces risk because your body's producing all the hormones as opposed to the exogenous hormones.
Thank you, Jamie. Catherine, I saw your hand was up. Go ahead with your question.
Yeah, thank you guys. Thank you, Jamie. One of the questions I have, it was great hearing that IVF is not showing to increase the chance with cancer resurgence. I actually caught my cancer because I was getting ready to implant. So I already had gone through 3 rounds of IVF back to back. I also happen to have had estrogen responsive or reactive cancer. So, so I don't know if that, could have moved things faster. But
yeah, sorry, you off the chapter. Yeah.
Yeah. My question is, I went through double mastectomy, had things removed. Cancer doctors are saying it's not there anymore. I want to make sure as I go to the next stage, if there's any doctors who understand fertility and cancer who I might want to talk with, because if there's different kinds of estrogen and progesterone I should be taking, it seems most of my medical teams don't understand one side or the other. They understand cancer or they understand fertility. They don't understand both sides. And I've had to connect the dots a lot.
Yeah, I mean, I think, unfortunately, I do think a team approach is best because medicine is so specialized now, right? Like, it's a joke in my family. Like, my kids will come to me with an ailment and I'll be like, I'm not a doctor. Like, why are you asking me this? They're like, Mom, you are a doctor, but like, I'm like, I don't know pediatrics. But the point is that the research does not show that fertility medications cause breast or ovarian cancer. But what it does show is if you have a breast tumor there and you do IVF, you probably will bring it out, right? Like, it'll probably present itself. In general, we ask women to get mammograms who are going to undergo IVF if they're above the age of 35. I'm not saying that we would have caught it or missed it, but that has always been our policy. I think the best thing to ask your team is, can I do a natural cycle? Can I put my embryo back in without any hormonal medications? And hopefully they'll be able to, if they don't know what they're doing in terms of how to do it, maybe they'll reach out to another colleague who does them frequently and that person can help.
Okay. All right. So it sounds like I'm probably higher. I started the process at 40 and I'm 42 now. So I'm guessing I'll talk to them about the natural cycle if at all possible.
Because if you're still getting, the only trouble, the times we run into complications are when patients stop going through they have their periods, or they're in menopause, right, from their treatment. So then you have to medicate them, because otherwise their uterine lining won't be able to receive the embryo. But if you're not in menopause, I think it's a great way to put the embryo back in.
Okay, great. Thank you. That's
You're
good to
welcome.
know.
All right,
trying to
Jamie, I have
find-
another question in the chat here that's
Okay,
asking.
here we go.
can you
Yeah,
speak
so
to the risk of fertility and post-treatment hormone positive cancer?
so then there's a question, can you talk a little bit about fertility post chemo? Yeah, so that's a great question. And unfortunately, Chick Mission does not, our motto is, or our philosophy, we help patients prior to undergoing chemo, but they don't offer grants for patients who've already undergone chemo. There are different organizations out there that will provide funds. What I have always seen in my patients is it depends on how old you were when you got your chemo, right? If you were a breast cancer patient in your 20s and you got chemo, there's a good chance your ovaries will still work and will still produce eggs. But if you got your chemotherapy or your treatment in your 30s, particularly above that 35-year-old mark, it's very likely that you won't respond robustly to those fertility medications. And while it's not, I can't say it's not a zero chance, the chances are not super high, and it's a lot of money to spend. So a lot of times I'll have a chat with patients and I'll say, where do you want to put your resources? Do you want to try and do an IVF cycle with a low chance, or do you want to try and do egg donation?
Jamie, there's another question in the QA portion. It says, what are the chances of getting pregnant on your own after treatment without egg freezing?
That's a hard question to answer, because I don't think we really know. I mean, people ask this all the time, like what's, especially patients who, let's say they fail an IVF treatment and they say to me, what's my chance of getting pregnant on my own? I'm like, I can't say it's significantly better or worse, right, than someone who's never been diagnosed with a cancer. But I think it depends on your ovarian reserve and how old you were when you received the chemotherapy. The younger you are, the better your ovaries are going to fare. Additionally, were you on any sort of protective medication as you were going through it? Did somebody put you on Lupron? Did you maybe not get one of the more toxic medications? I think all of these are probably going to translate into a higher risk of infertility.
I see one last question, I believe. How long would you suggest being off of tamoxifen before doing the natural placement of the embryo?
That's a great question. I think in general, I've spoken about this with a couple of oncologists. We generally say like 2 to 3 months. It's not a long period of time. For a while, we went back and forth with this recommendation. Like, did you need to be off for 6 months? Did you need to be off for longer? But in general, we really have become quite comfortable with that 3-month mark, and then you can sort of go into the process of transferring.
Okay, I think we've got all the questions. Ladies, I just wanted to say thank you for all of those questions. I think it might be a little bit easier for Jamie if when we start asking our questions, if we don't put them in the chat, but we raise our hand and then we can go off of whose hand is raised. Might make the flow a little bit easier for us here. All right, Jamie, go ahead.
God, I'm trying to think what other things I can share. I guess the most important thing I would share, and I've spoken a lot about this with a lot of women, is that be your biggest advocate, right? Because nobody is going to affect more change for you than you, right? So I think that if you can take the time and ask the questions of your team, I think you'll probably get the best care, because you sort of navigating for yourself is really going to give you the best outcome. I can definitely talk about different areas of fertility if there's anything people want to talk about, like if anyone wants to talk about surrogacy or egg donation or embryo freezing. I'm happy to ask any of those questions. Answer, sorry.
Looks like Maya has a question for us. Go ahead, Maya.
Thank you so much. So I was able to freeze some eggs before my chemo, and I was only 29. My question is, when I'm off that 5 years mark of tamoxifen, should I try to do naturally, or should I go for those eggs? Because I know there's a window of time, and how would I approach that?
Do you have a partner, Maya, with whom you want to have a child with?
Not yet.
Okay, so then I would say you want to hold off on using your eggs until you know or have the individual with whom you're going to have children. If you are going to plan and do this on your own and use a donor sperm source, then you could certainly thaw your eggs, fertilize them, and make the embryos. But I think the eggs can stay frozen as long as you want them to. They don't have to be defrosted, so to speak, right? They don't have an expiration date. They should stay frozen until you have a sperm source that you know is going to be the individual or the source that you want to have your kids with. So I would wait until that time.
Thank you so much.
Thank you, Maya. It looks like Lauren had a question. Her hand was up. Lauren, did you still have a question?
Yeah, hi. I think you pretty much answered it. My question was going to be if there was an optimal time in which frozen eggs should be used. If there's a reduced chance of a successful pregnancy, if they're frozen for, longer than, I don't know, 5 years or 10 years or something.
Yeah, I get asked this all the time. And I always say, in like a funny / not funny way, eggs are not like chicken in your freezer, right? Where you go in and you're like, oh dear God, that's been there for 5 years. Like that has to be thrown away. Once your eggs are submerged in liquid nitrogen, they can remain frozen for as long as you want them to be frozen. The problem is you will get to an expiration point, right? You will get to a place where it is too risky to be pregnant. The American Society of Reproductive Medicine says that age is really 54, right? So ideally you should get pregnant before that. But I will say that pregnancy complications, diabetes, high blood pressure, go up dramatically as we get deeper into our 40s. So while the eggs can stay frozen as long as you want, there will be a time at which your pregnancy complications will become too great for you to carry a pregnancy.
That was a perfect segue because Andrea would like to hear more about surrogacy.
Yeah. So surrogacy is an amazing way for couples or individuals to have families. When pregnancy is too risky for a cancer diagnosis, another medical diagnosis, somebody doesn't have a uterus, a surrogate is a great option to have a family. The biggest problem with surrogacy is it's very expensive and almost no insurance companies will cover it. So that's when patients really get to a place where they're not sure if they can do it, is because of the cost, right? So if it is something that can be done, we will create embryos, just like, when somebody goes through IVF, egg and the sperm come together as an embryo, we grow them in the lab, and then those embryos undergo genetic testing for chromosome number. And then once we have viable embryos, we will transfer an embryo into a gestational carrier. There are agencies out there that identify women who are good candidates to be surrogates and match them with intended parents. And the surrogate will carry the pregnancy for the intended parent. Did that answer it a little bit, or?
Any other questions, ladies? Anything else you guys interested in having Jamie go over for you?
I
Amy,
just
have a
also,
question. Can we
sorry,
talk
yeah.
a little bit about what women can expect? Is there higher risk in these pregnancies? Can they expect to have a little more of an in-depth relationship with their OBGYN with them being pregnant after a cancer diagnosis? Is it more of a high risk pregnancy? Are there things that they need to look out for?
I think these are great. That's a great question. So yes and no. I always say it depends on what surgical and or chemo that you got prior to getting pregnant, right? So if a patient, let's say, got a lot of doxorubicin or adriamycin, that may have made their risk of congestive heart failure higher, I may say, you know what, you should be seen by a high risk OB, because I think there's additional risk. If there was a medication that maybe reduced your lung volume, that may make pregnancy more challenging, you should see a high risk doctor. But on average, most of the pregnancies are pretty low risk, right? Because most patients are still left pretty healthy after they go through their chemo and their surgery. So while I definitely think it's a good idea to establish care with a high risk doctor and to review all the potential risk factors, I think carrying a pregnancy is usually something that most women can do. I think maybe Catherine said she had another question. I think I saw that come into maybe I saw it in the Q&A.
Yes, I saw Catherine said she had another question. Catherine?
Okay, thank you guys. My other question kind of goes back, Jamie, to what you were just talking about as far as, again, the aging component. The eggs don't get older, but the people do. And the other part of all this was while I was going through IVF and COVID wasn't helpful to me with my weight, yada, yada, yada. I'm overweight now. And so as long as my innards are all up to par, my approach was going to be after I get through reconstruction with my cancer, with my mastectomy, try to get into a more healthy weight range. But I wanted to get guidance on that if that's probably a good approach, because I'm not in a healthy weight range. So I'm thinking I have 2 embryos and I want to be the best incubator unit when that comes, but it's a trade-off because I'm also getting older. So yeah.
Those are excellent questions. So this is the process about reproductive age. So reproductive aging is really ovarian aging, right? Like our uteruses can be manipulated to do whatever we want them to do for years and years past menopause. We're not advocating this, but if you go onto Google, you'll see like 75-year-old woman gives birth in India. And while we're like, oh my God, the reality is that your uterus can be manipulated to do almost whatever you want. The end, or really what dries up, is egg quantity and egg quality. And I say this like, it's not, and I'm probably older than almost everyone on this talk, but like, it's not our mom's fertility world anymore, where most women have their babies in their 20s. And that's really when our ovaries are ideal and our egg quality is ideal. As we dip deeper into our 30s and our 40s, we're running out of eggs, but our bodies are still pretty healthy, as are our uteri. So I think it's a really smart idea to get yourself in the best place possible for pregnancy prior to transferring, because if you have those 2 good embryos and you want to give them the best environment, I think doing anything to make that better is great. So I'm totally in support of that.
Excellent. Thank you.
You're welcome.
It looks like Andrea has a question for us as well. And then we have a question in the chat after Andrea. Go ahead, Andrea.
Oh, thank you. I was curious, what our periods are, what they indicate post chemo. In my case, it came back after a couple months and I thought, yay, great. It's not destroyed. But I realized that I actually don't thoroughly understand this biology. So I'm curious,
Yeah.
getting a period of anything.
Yeah. This is a great question, Andrea. And I came up with this slogan when I was a fellow, and I'm not saying it's a good slogan, but I would say menses doesn't equal motherhood. And what that means is just because you get a period, it does not mean your eggs are of the quality that they need to be to conceive a pregnancy, right? So while it's a great sign that your ovaries are still producing hormones because the lining of the uterus is thickening and shedding because of the rise and flow of the hormones, it doesn't tell us if the quality of your eggs is good or not good. So that's really why there's a false assumption. And I think not only by patients, but even by oncologists or internists, like, oh, they got their period, they're fine. I'm like, no, that is not what that means. Yes, it means that they are not in menopause, but it does not speak to the quality of their eggs.
What would be good timing to go in and have the AMH and FSH looked at post-treatment?
Yeah. I think as soon as you're sort of ready to try again, go in and see what the ovarian reserve is showing you. Now, yes, there's going to be a suppression post the chemo, right? Because chemo sort of knocks the wind out of your body. Everything is sort of down. But if you are a few months post chemo and your menses have returned and you're like, I want to see where I'm at, that's a great time to go in and check.
Thank you so much.
All right, we also have a question in the chat from Morgan. Morgan asked, can we talk about basics of chemo-induced menopause as it relates to fertility? Should we lean on surrogacy?
Good question. So if you have eggs or embryos frozen and you go into menopause post chemo cancer treatment, you can still carry a pregnancy because we can give you estrogen and progesterone sequentially to make your lining thicken and grow. So being in menopause post chemo does not mean that you cannot carry a pregnancy. We can't use your natural cycle, but you can certainly carry a pregnancy. You'll be able to deliver. All of it will be totally like anyone else's.
I see another question in the chat. It's a little specific. So generally, she's saying she retrieved 36 eggs. How many of those will be actually used? So I guess in general, how many eggs are used upon a retrieval?
So that's a great question. And I always say that this is the thing. Eggs are extracted. They are a cohort. They are a group of eggs. So ideally, when you come back to use them, you should use the whole cohort at once, because that gives you the most cost effective, the most time effective, and the most successful way to collect embryos. The times that I tell women to maybe hold off and thaw a subset is if a woman says to me, listen, I'm here, I don't have a partner, I want to be a mom today, but I'd like to reserve the opportunity to have a child with a partner. I might say, okay, let's thaw 15 eggs and keep the other 20 frozen for the future. But if a woman comes in and she has a partner and they are hoping to have their whole family, I say, let's thaw all the eggs because let's see how many good embryos we have. Additionally, you have to remember that frequently we're not only thawing eggs and making embryos, we're doing chromosome testing. So we want to make sure the embryos have the right chromosomes. And we're frequently looking for single gene genetic mutations, BRCA, CHEK, HNPCC. So we're looking for mutations, and these cancer mutations affect 50% of the eggs that are released. So if you had 36 eggs, let's say you thaw them, let's say 32 survived the thaw. Let's say of the 32, 28 fertilize. Of the 28 that fertilize, let's say 12 make it to the advanced stage because a lot of the embryos will stop growing. Of the 12, you may get 8 that are chromosomally viable, but maybe only 4 that don't have the genetic mutation. So the step down is so steep. And in order to be efficient and conscious of cost, I'll often thaw all the eggs at once.
Thank you. I do see another question in the chat. Very good question. If one has frozen eggs or embryos, can you talk a little bit about the implantation process? Is one given hormones that may be problematic if there was a hormone-sensitive cancer?
Yep. So if you have eggs frozen, before those eggs can be transferred, they need to be made into embryos, right? So they need to be thawed and fertilized with the sperm source. Once you have embryos, there's a couple of different ways to transfer embryos into the uterus. One is with a medicated cycle and one is with a natural cycle. Natural cycle simply means we're going to use your natural menstrual cycle to put the embryo back in when you're about a week after ovulation, which is when most people are getting, when an embryo would be sticking. I prefer the natural cycle for almost everyone, breast cancer or not, but particularly for my breast cancer patients, because I want to limit their exposure to exogenous, or let's just say something that their body isn't making, estrogen and progesterone. So that's why I'll opt for the more natural approach.
Okay, ladies, any other questions that we can think of? Anything else we'd like to go over a little more in depth, maybe?
I think somebody just asked, hold on, Jamie was mentioning you asked to see where you're at. Was it? Oh, okay. Yeah. So you can ask for an AMH level. That's called the anti-Mullerian hormone. And it does tell you a lot about your egg quantity. So AMH does not tell you if you're fertile. So I say this to women who are freezing their eggs all of the time. There is no test to see if you're fertile. That's totally BS when people advertise like, oh, I have the fertility test. I'm like, that's not true. Nobody has a fertility. Nobody knows if you're fertile or not. We can test egg quantity. By knowing egg quantity, we can say, okay, if you do IVF, if you do egg freezing, if you do this, this is how many eggs you're going to get. And that's normal or average for your age. But it does not say if you're fertile or infertile. So it's really, really helpful for patients to know that, because I see a lot of women who come in like devastated. They're like, I had the infertility test and I'm infertile. I'm like, what's that? Because I don't know what that is. You know, so I think that's super helpful. Oh, I see something. So there's no way to test egg quality before a retrieval. Impossible to know. In terms of diet and supplement, you know, listen, I feel very mixed on this. Like, I think it's unfair. I mean, everyone here, myself included, is a breast cancer, not just breast, but cancer survivor. And I always felt like, did I do something to cause it? And I found it like, it almost made me feel worse, right? I was like, oh, I used to use all this equal in my coffee, or like, you know, I drank so much Diet Coke, and that like puts the blame on you when it's not your fault, right? Like you did nothing. It unfortunately just happened to you. When patients talk about or are told, if you take this supplement, if you use this diet, your infertility is going to go away. I'm like, that's totally BS. We know that's not true. Do I think that we should live healthy lifestyles? Of course. Have I tried to remove some things I used to do that I think were probably not great? Yeah, I have. But people get pregnant, you know, doing crack cocaine and heroin all the time, right? Like, and so for me to say to a woman, if you took this supplement or did acupuncture, you wouldn't have infertility. That's just like horrible. Not only is it not true, but it makes the person feel 100 times worse.
I see another question. I think they're asking if there is something that that would help them with the quality of their eggs.
Yeah, no, there's no proven test for egg quality. Yes, supplements are something patients take frequently to try and see if it improves it, but there's no definitive data that is going to say, oh, if you take these supplements, then your eggs are going to get better, because we don't know how to change egg quality. I always say, like, your eggs are like your worst best friend, right? Or your best worst friend. They were there and they saw everything you did. They were like, I know what you did that night. I know where you were, like all that, right? So just by saying, okay, now I'm going to take a supplement and that's going to change my egg quality, it's not going to go like that. Can it help you feel overall better? Do we all feel better when we take certain supplements? 100%. But I don't think there's one supplement or two supplements that make you more fertile or make your eggs better quality.
I have a quick question for you, Jamie. Can you tell us a little bit more about the Chick mission?
Sure. Chick Mission's like my favorite thing to talk about. So the Chick Mission was started by a woman named Amanda Rice, who herself is a 3-time cancer survivor, 2-time breast cancer survivor. Amanda was diagnosed, I want to say in her late 30s. Maybe even early 30s. And she was appalled at the cost of egg freezing and that it wasn't covered by insurance. So this motivated her to start Chick Mission, which is an organization that provides grants or funds to women who are diagnosed with cancer ahead of their ahead of their cancer treatment. And that's really where, Chick Mission was born. And Amanda has surrounded herself with incredible people who have helped push the mission forward. And we've now given hundreds of grants and helped hundreds of women. And it's really something that I'm very honored to be a part of.
Awesome. We have about 13 minutes left here. Is there any other questions that we haven't touched on or anything else that you all would like to ask Dr. Notman?
I put another one in chat. I have lots of questions.
Oh,
Go ahead, Catherine.
I can ask it too. The Ozempic, just wondering if there's been any studies around that. Is I don't have diabetes, but again, I'm overweight right now.
Yeah, it's a hot topic. So the thing about Ozempic for us as fertility doctors is you can't be on Ozempic when you undergo a retrieval. The Ozempic will it's increasing the risk of what we call aspiration pneumonia. So people are vomiting their stomach contents during egg retrieval, colonoscopy, endoscopy, because the Ozempic delays the gastric emptying. So we are telling our patients who are on these medications that they need to be off of the medications for about a month in order to reduce their anesthetic risk. We have not seen that it impacts their egg quality, but we are definitely seeing risks in the procedure. In terms of pregnancy, as far as I've heard, I think most of the OBs are asking patients to be off for about 3 months before conceiving. I would imagine as time goes on, more and more patients will be on it, or more patients will conceive on it. So we'll definitely get more data.
Good deal. Yeah. And I'm, again, my particular spot is I already went through, fortunately, a lot of the retrieval piece. I'm now in the getting ready for implantation piece.
Yeah.
So it sounds nothing definitive, but it may be a good time, if it works for me, if it works with my body, to try that now before I go for that.
I think it definitely would, I think if there's a time to do it, now is probably the time.
Thank you. This has been so helpful. Very great information.
Thank you. I always say, listen, I had breast cancer and I'm very open about that. I happen to have already had my kids, so I didn't go through what a lot of women on this call or a lot of women I meet have to go through, which only makes me respect people more, because it was daunting without doing egg freezing or thinking about my fertility. But I truly believe that my having cancer made me a better doctor, because I think one of the hardest things about being a doctor is having true empathy. And I don't think there was any other experience in my life that really taught me what it's like to be like going down the path and then get like someone punch you and you're going the other way. And so I have so much respect for everyone on this call, or everyone who's had to think about not only healing themselves from their cancer, but also dealing with their fertility and like, what was that stage of their life going to look like?
Well, as our time is wrapping up, I did want to touch on just a couple more things. First and foremost, I want to say thank you to Dr. Notman. This has been such a wonderful experience. Everyone in the chat is just singing your praises. Thanking you so much for all the information you've provided. We are also appreciative of you. Please, everyone, remember, On the YSC website, youngsurvival.org, you can find all of this information. The recording will be up for 30 days. Please make sure that you are registered for the summit to have access to this recording. Also, all of the participants, you'll be receiving an evaluation via email. So it is important that you register for this so that you can receive that email. Give us an evaluation of how this went. We would very much appreciate that. And you will be entered for a drawing of a $50 gift card if you take that evaluation for us. Thank you again, Dr. Notman. Thank you everyone for participating. We really enjoyed this. It was a lot of information, and hopefully you all got a lot of takeaway from this as I did.
Thank you so much for having me. I really, I appreciate you. I appreciate reaching out and having the opportunity to come and chat with you all today, and enjoy Saturday.
Yes, happy Saturday, everyone. Have a wonderful day.
Bye, guys.